Καλησπέρα σας. Είμαι πολύ χαρούμενος που σήμερα ξαναβρίσκομαι κοντά σας σε αυτή τη σειρά των webinars. Η πρόεδρος μας, η κυρία Καμποσιώρα, είχε μία επαγγελματική υποχρέωση και δεν μπορούσε να παρουσιάσει το σημερινό webinar. Επομένως, μπόρεσα και εγώ και έκλεψα τη θέση της για να ξαναβρεθώ κοντά σας, γιατί ξέρετε πόσο μου αρέσουν αυτές τις Τετάρτες. Σήμερα είμαστε πολύ χαρούμενοι. Θα γίνει μια παρουσίαση από την εταιρεία ΤΣΑΠΡΑΖΗΣ, μία από τις πιο δυναμικές και, μου επιτρέπει, στις αρχαιότερες εταιρείες. Εγώ, όντας γιος οδοντιάτρου, έχουμε συνεργασία με την εταιρεία για πάρα πολλά χρόνια και ως πρόεδρος της Ελληνικής Προστατικής Εταιρείας και τώρα Ταμείας, είναι από τις εταιρείες που είναι χορηγοί μας μόνιμα για πάρα πολλά χρόνια και τους ευχαριστούμε, σας ευχαριστούμε Ήρης γι' αυτό. Εκτός αυτού μας συνδέουν φιλικές σχέσεις. Σήμερα θα έχουμε μία πάρα πολύ ενδιαφέρουσα παρουσίαση για flowables, τα οποία χρησιμοποιούνται με την τεχνική που θα σας δείξει ο Dr. Itay, την οποία έχει κάνει και develop. Και είμαι σίγουρος ότι όλοι θα την ευχαριστηθούμε. Βλέπω ότι έχουμε πάρα πολύ κόσμο και θα έχουμε ακόμα περισσότερος, οπότε μου επιτρέπετε να σας παραδώσω στην κυρία Τσαπράζη για να παρουσιάσει τον ομιλητή. Dr. Itay, thank you very much for being with us. I did a small presentation saying that we collaborate with Tsaprazis company for many years, and being the son of a doctor, of a dentist, we were collaborating with her father when the company started, and we are very happy to have you with us. And I turned, the microphone to Ms. Tsaprazis to be able to present you. Iris? Thank you.
Okay. Να καλωσορίσω και εγώ με τη σειρά μου τον ομιλητή, τον Dr. Itay Mishaeloff. Να σας ευχαριστήσω και την Προστατική Εταιρεία για αυτή την δυνατότητα και αυτή την εξαιρετική οργάνωση. Να σας παρουσιάσω τον Dr. Itay. Ο Dr. Itay πήρε το ντοκτοράτο το 2003 από το Semmelweis της Βουδαπέστης. Είναι ο εφευρέτης του συστήματος IVENEER, το οποίο και θα σας παρουσιάσει και για το οποίο θα σας μιλήσει σήμερα. Έχει το δικό του ιατρείο στο Τελ Αβίβ και έχει υπάρξει ομιλητής και key opinion leader σε πολλές άλλες εταιρείες και σε πολλές άλλες ερευνητικές επιστημονικές εταιρείες. Dr. Itay, I just presented you to the participants, and the floor is all yours. And you are welcome.
Thank you very much.
Good.
Now, let me see. I don't see my. Oh, now I see. Now it's okay.
Good.
Can you see everything?
Yes, it's great.
I see. I will close this window. Oh,
I just want to remind the audience that we are expecting your questions during the presentation, so we can talk about this nice technique afterwards.
Yes, of course. Wait a minute. I just want to see why I cannot close this window. Yes, now it's okay. So, hello everyone. First, I would like to thank you all for taking the time from your busy schedule to be with me for the next hour and a half. And again, I want to thank Hellenic Prosthodontic Society and Miyama Institute and Iran. Thank you very much for the invitation. I would like to share with you my passion and experience with direct bonding and how we can approach it from a unique perspective. I want to show you how we can use them in a way that will enhance people's smiles and at the same time will enhance our clinical outcome in a simple way. All these photos that you will see in my presentation are real-time pictures, and these are mostly from my clinic. I took them with my phone, and all are direct composite cases of minimally invasive or non-invasive smile enhancements. Before we begin, I want to share with you a case I did in 2010. Sorry for the picture, it was a long time ago. This was a severe discoloration on tooth number 22, and in this case, back then, I decided to go with a crown. And this was the result. At that time, I was quite happy, but I want to tell you that today I think differently. Today, I would use direct composite because I know that I can achieve better results. Before we start, let me just tell you about my journey to restoring with direct composites. And now I use direct composites exclusively in my clinic. I use mostly the flowable composites from the new generation. 10 years ago, after many years of performing different aspects in general dentistry, I decided to work with direct composite exclusively. And the way I was using a direct composite, it was with conventional layering technique or the stratification technique that you know. The results were good, but most of the time I wasn't so pleased with these results. So I felt it was time-consuming and unpredictable. 6 years ago, I discovered the new generation of flowable composites, and I began using them with an anterior region for the anterior region to save time and overcome stress and anxiety. I knew that they had a superior physical and mechanical characteristics. But the problem was the handling. So I tried different ways, and I found out that the best way for me to use the flowable composites freehand was using a probe, and I used it with a circular motion. So this was my technique. You can see it here. I was putting the flowable composite, and I was with a probe, with a circular motion, I created the shape. So this was my technique to work with flowable freehand. And this is a picture that I took, again, long time ago, before I used any kind of template or tool to hold the material. With this technique, I enhanced my aesthetic abilities, and I was able to work faster and got better results with time. But the problem, as I said, was the handling. It requires skills in controlling the shape, and in many cases, I had to cut back because of voids, air bubbles, or it was bulky, so I had to cut it back. I was always thinking about how I can solve this issue, and eventually I came up with an idea of injectable templates to solve these problems. So this presentation today is about a new approach, new working with flowables. Moreover, it is an invitation to you, doctors, to think differently and maybe consider direct bonding as an option that we can offer to our patients, an alternative to invasive treatment in the anterior region. Let me show you a quick live clinical case, again from my clinic. One of my patients came urgently with a broken ceramic veneer that I did on tooth number 21 that I did maybe 15 years ago. And the problem was that he didn't have time and the money to do a new ceramic veneer. And I didn't want to go for a freehand composite veneer as well, because at the time, I got a new prototype template that I was working on. And I was asking this patient, maybe I can try this new template on his teeth. And to tell you the truth, I was a little bit nervous because I didn't know if it works and what will be the result. Me and my partner worked on this invention for 4.5 years, and I didn't know if it will meet my expectation, but I want to show you how it works. As you can see, this is the template. This is but a cut wing template, so I could manipulate it. I cut the wing and I tried it onto the teeth. Of course, the protocol of preparing the teeth, removing all the broken ceramic was done earlier. And I also built a freehand palatal shell and try the matrix, see that it sits passively, and inject the material through the hole. I cured it, removed, and I was amazed about the results. Me and my patient, we were amazed. So you can see a collage of many cases that I did since then with flowable composites from the new generation, the universal one. And since then, I practice dentistry. My practice has changed tremendously. I'm using this chairside injection molding technique, improving it and expanding it all the time to a wide range of use cases and indication. And today, my practice is 100% direct flowable composites, exclusively flowable composites, and it enables me to work faster and offer my patient a non-invasive smile enhancement options. I receive a lot of cases from many dentists that work with my technique, and you can see here in the picture from my media, patients from my clinic, how they are happy. So one dentist named Dr. London from the United States uses this matrix a little bit differently. He used this matrix with paste composite material, and I want to show you how. He put the paste composite material inside the matrix and push like a spoon onto the teeth. And then he cures it. A little bit finishing and polishing. That's his technique. And another influencer of this dentist has to say a couple of words. Usually this video has a voice, but I guess you don't hear it, so you can read it. Many years he had low self-esteem, self-confidence with his teeth. But it's about to change. So this Dr. London was the first to work with this technique. And that was the result. Unbelievable. I would like to talk about some past beliefs. I believe that before we adopt new concepts or techniques, we should first change our mindset regarding previous thoughts. Direct composite resins is often considered inferior to ceramic or to other materials. But in fact, practicing composite bonding can offer many opportunities and advantages for highly aesthetic smile enhancement results that we should consider. I really think we should consider before other options and before we cut healthy tooth structure. Some beliefs. We use direct bonding often for minimally invasive restorations. It's highly effective and essential for our daily work. So what prevents us from choosing direct composite as the first treatment option in anterior region? Is it because it is prone to chipping or discoloration? Maybe it's not profitable, or the aesthetic is not good enough. Let's talk about chipping. Chipping is the very common question among patients. There are two factors that involve the chipping: the strength of the material and the applied force. But we have a solution. Designing the appropriate thickness, which should be between 1.5 to 2 millimeters in the incisal area, thickness, with a high quality composite resin, with the high field composite, the universe, the nano field composite, has sufficient strength. And with the balancing of the bite and sharing the load among the teeth, we can solve premature and deflective contacts. What about the discoloration? After many years of experience with different types of composite, I can tell that not all composites are equal. In this picture, you can see a high quality flowable that allows excellent color stability over a period of 5 years. It is important to note that while some composite may change color over time, this does not necessarily mean that all composite will discolor or stain if we choose the right one. So we should pick the good composite, universal, high quality brand, between 60 to 80% filler rate. This is another patient that returned for a follow-up after 3 years. I did 3 composite veneers on tooth number 11 to 22. And I used a high quality flowable material, and the patient main concern was when he came back to me after 3 years that he feels some roughness texture on tooth number 21. So I made some quick finishing touches and polishing, and it just returned to the original state. And this was after the finish and polish. So you can see how simple we can fix it. What about that? This is very difficult process and frustrating. So I can say yes, working with layering technique is difficult, frustrating for most of us. And as I mentioned earlier, that was the reason I switched to freehand flowables. During this time, I have developed unique techniques, and I will show you how to do it. Takes a lot of time. I mean, when we do an MOD, a big MOD, it can take approximately 30 to maybe 1 hour. And we don't say it takes a lot of time. So regarding composite veneers, or working with direct composite in the food area, a trained dentist with the right materials and techniques can do 6 to 8 in 1 hour. So I guess we can consider it very fast and productive. Productive. I have to tell you, and I say it all the time when I give lectures to dentists, that I'm more productive now doing exclusively direct composite smile enhancement than I used to do general dentistry. With the level of my expertise and the use of flowable together with adequate tools and techniques, dozens of composite veneers in a day is not a fictional number for me, at least. And I guess you can do it as well. My clinic is doing exclusively direct composite veneers, and I must tell you that I work less and I have more time with my family while I'm more productive and profitable than I have ever been. You can do it. Aesthetic results. I really believe that when it comes to composite bonding, direct composite bonding, nothing beats when it comes to aesthetics, composite bonding. You stay conservative, minimally invasive, additive. Of course, the beauty is in the eye of the beholder, but But the truth is that direct composite can achieve natural aesthetic while preserving healthy tooth structure with minimal invasiveness. So in my opinion, and I hope you will think so at the end of this presentation too, that direct composite can rival other materials in terms of quality. This case was done on a 16-year-old boy who felt insecure about his teeth. The patient, he refused to go for orthodontic treatment, and I myself, and knowing that the process is predictable, entirely non-invasive, reversible, and additive, both of us together, we decided to go for composite veneers. So I think this treatment can greatly improve the quality of life for young patients without the need to shave their teeth. If I summarize, direct composites offer advantages that cannot be found in other materials. So you ask, what are these advantages? I can say it is customizable, so we can have predictable color matching, because we are in control. We control the material. If we want to lower the value or to add effects, we can do it. We can customize it until we like the fit. And with other material, for example, ceramic, we do not have the ability to go back and layer different. Recently, a new category of flowable composite known as universal flowable composites, or next generation flowable composites, or nano flowable composites, nanotechnology flowable composites have been introduced. These are highly filled and designed to restore all types of cavities. I want to share with you an abstract from the International Association for Dental Research. The objective of this study was to compare the mechanical and structural analysis of these universal high-field flowables with the regular flowables and the conventional composite. And the conclusion was that universal flowable composite with different structures, they present highly improved mechanical properties than the traditional flowable composite materials. So it's really important to pick up the high quality, the high field flowable composite. Another one, this is another abstract from the Journal of Medical Behavior of Biomedical Materials, with the conclusion that the flowable composite resin, there is a type of flowable composite resin that are universal and they have superior properties than other traditional resin. But it says that the handling properties of this composite vary depending on the material being used, which means they have a very good physical and mechanical characteristics, but it is very difficult to work the handling with them. So how can we use them more effectively for our anterior region? I would like to examine with you a new matrix created to enhance the use of these flowables and resolve any handling concerns. A quick summary before on different traditional bonding techniques available today, the advantages and the disadvantages. So as all you know, the freehand layering technique, we have the pros, we have the cons, but if we summarize it, the pros are that it's a really good technique if you master it. Okay, it enables the creation of realistic incisal effects and offer effective control over the shape of the teeth. And if done correctly, it can yield very impressive results. But the learning curve is very steep. A very skilled dentist should be, and it can take a while. It requires much practice, and it demands a high level of manual ability, and it is a pretty time-consuming. And eventually the outcome is heavily influenced by the practitioner emotional state and the level of the expertise, making it difficult to get predictable and consistent results. But I have to say again, some dentists, they master it, but most of us, it's very difficult and frustrating for us. We need tools for these freehand layering techniques. You may already be familiar with these products, the Toffelmir, the modified Toffelmir, added one, the Mylostrip, celluloid, sectional matrix, metal, sectional matrix, metal or plastic. These tools prevent the material, the composite, from sticking, adhering to the neighboring teeth, but none of these products gives the full solution. We cannot create the shape. It doesn't give us the full shape that we want. So there is no final anatomical shape. What about the prefabricated veneers that are ready for use and provide both strength and glossy finish? The problem is that they are not custom made. They need a lot of adjustments, and the final appearance may be bulky, and of course they are not suitable for all situation, and the price is expensive. And what about the plastic spoons? The product is stiff. It is a plastic, so it cannot be customized to fit the teeth, and mostly it relies on the dentist, the doctor, the user, how he press the technique, how he press it onto the teeth. So the final result depends on the pressure applied by the dentist. And last technique that I want to talk about is the injectable mold technique. And I want to emphasize that when it is done properly, I guess a lot of you doing it with flowable composite, the result can be very exceptional, especially regarding the anatomical outcome. But this option is very complicated in a way that it requires a lot of seats, and it is not a chair side. You need a lab. The learning curve is quite steep. I wouldn't do it for a single tooth, of course. There is a difficulty to isolate with a rubber dam, and of course the high costs. And it is mostly for monochromatic. Okay, after all this introduction, let me introduce to you with the new technique, how to do direct bonding with IVENEER injectable matrix system and flowables from the new generation. This is the IVENEER matrix. As you can see, it consists of several parts. It took us 4.5 years to get to the final design. I wanted to clone or to merge all the advantages of the other tools, other matrices, into one solution. And you can see that it has a very thin, I will try now to do with the laser here. It has a very thin interproximal area to go in between the teeth through the contacts, what you cannot find in other matrices. It has an anatomical design. It was taken from natural teeth. And it has a hole or a stalk through which we inject the flowable composite. Also, you can see that it has wings, so we can hold it and adapt it and push it through the contacts with the wings. It can be adjustable. It's a huge advantage that you can adjust the matrix to fit the teeth, and many more advantages. This technique is suitable for many use cases. From chipped to broken teeth, class 5, crowded teeth not requiring orthodontics, severe teeth, multiple diastemas, darkened teeth, peg lateral, and even for crowns. So I've developed many techniques and use cases how to work with it, and I will show you. But many dentists ask me the question, do we have to change the protocol for this technique? And the answer is no. The protocol is the same. This is only a tool. It's a matrix. It's a template. Just like other tools, other matrices, or Milo strips, or other tools that you use, you don't change the technique and the protocol. And the protocol is, first, we isolate. We can use a Teflon or rubber dam, and we then do the preparation. It can be a minimal preparation or no preparation. And then it's very important to choose or to pick the right IVENEER matrix. And this matrix fits to the corresponding teeth. So there is no only one matrix that fits everything. Each tooth has its own matrix. This is important. And of course, we choose the matrix. We have to try it for a passive sit. If it doesn't sit passively, we can trim it. We can push it then through the interproximal contact points, 0.5 millimeter into the gum line. We see that it sits passively, and then we can continue. We take it out and we continue with the protocol, of course, of etching and bonding. And then we set again the matrix. After we tried it, we set it because we know it will fit again. We set it again. Some techniques, tips, and tricks that you will learn, but we close from behind to create a closed system. And then we inject the material with pressure so there are no voids or air bubbles, and we cure it. Of course, removing the matrix and a little bit finishing and polishing. And since this matrix creates it is a closed system, so it will interfere with an oxygen inhibition layer. So once you take it out, it will be, the final result will be shiny and glossy. I would like to show you some clinical cases from my clinic and discuss about them. So this patient wanted to restore the front tooth, the 4 upper front teeth, 12 to 22, but he wanted to keep the natural color. So in this case, I used the 1 shade with the IVENEER matrix to close the diastema and to restore the shape and the length. And I want to show you how I did it. This is the before. And then I used a Teflon for retraction as a retraction cord. I built a freehand palatal shell at the incisal area. As I told you, I tried the matrix, I manipulate it, and I set it onto the teeth, close from behind with a flowable, and inject the material, clean the excess with a silicone brush, cure it, remove some finishing and polishing. It is important to work 1 tooth at a time. Again, the second matrix, after we tried it, onto the teeth, clean the excess, inject and cure, removing, and this is the final result. Another case for shape and diastema as well, but in this time, the technique is the IVENEER matrix together with a metal, a sectional metal matrix to make a tight contact points. And I want to show you how we did it. The first one was done already, and then I took the second matrix. I secure with wedges. Note that I'm not trying to close the diastema first. First time I build both of the teeth, and then you will see how I can close the diastema with the same flowable composite material. So here I put a matrix and I close from behind to create a closed system. I don't push the material inside because now I will cure it and then I will stabilize the matrix by curing. Remember, we did already the etching and bonding, okay? So we cure it and now it is stabilized and I can inject the final layer that I want. In this case, it's A1. You can see how it spreads evenly inside with no bubbles. Here I use again a new syringe because the first one was ended. I clean at the cervical area. And why I do it? Because I don't need later on to work with a diamond burr. It's not necessary to cause bleeding. I cure it. And I remove gently with a probe. And look how nice, how the finish line is so nice. But now there is a small gap and I want to close it. So I use a sectional matrix. This is a Garrison sectional matrix. It's a very thin one. Create pressure with my finger a little bit towards the midline. And with the same flowable composite material and a silicone brush, I just sweep it and I cure it. And this is the final result. So 2 steps. One with the matrix, second one, the second step is with the sectional matrix. So simple. Another result for 1222, final result. This one is an interesting case because, as I told you, we can work with this matrix with flowables by injecting, or we can work with the paste composite. And in this case, I was working with a paste composite material to restore tooth number 23 because of shape and color. The patient wasn't satisfied with the shape and the color of his tooth, and I decided to go with the matrix. In this case, the technique was wingless, so I manipulated the matrix. You can see that I cut the matrix, and when I cut the matrix, I cut the wings, but I don't touch the interproximal very thin area, which is 0.05 to 0.06 millimeter, because it's like knives. When I put it inside, push it inside in between the contacts, maybe it won't go through the contact, but it will create a seal. But I also decided to put some Teflon here just to make sure that there will be no excess that will stick. So I cut the matrix, I push a paste composite material inside with a silicone brush, and let's see how it works. Isolation, etching, bonding, of course, trying the matrix after cutting the wings, removing the matrix. In this case, I used a gun with a carpool composite syringe, and working with a brush, I use some primer, very, very thin layer of primer to manipulate it. And like a spoon, I push it inside. And very important, don't cure, remove the excess gently, and then cure it. So simple. Remove the matrix. Oh, what happened? It's stuck. Okay, I'm sorry, but it ended. But believe me, the results are great. Another interesting case that I wanted to show you, the patient was concerned about tooth number 21 because the gum line wasn't perfect. And we can approach this case differently with the cutting with laser and the orthodontics and so on. But I decided to use the matrix and the Toffelmir matrix, or the modified Toffelmir matrix. It's the Unica, you know, the Unica. So we can take this matrix and use it as the Unica if we cut it. So I use this matrix, the metal matrix, to create seal interproximally and to be able to push the gum apically for 0.5 millimeter. And the tooth also is positioned palatinally. So I wanted to bring the buccal surface that it will be even with the tooth number 11. So what I did, I used the modified Toffelmir matrix. I cut it like Unica. I pushed it 0.5 millimeter, the gum apically, and then I used the IVENEER matrix. You can see here I pushed the gum and then cut wing. We cut the wing, we leave only a very thin interproximal area, and I put the matrix inside, and it fits perfectly. And then I injected the flowable composite material, knowing that I have an isolation in between the contact and the cervical area. I removed both of the matrices and I did a finish and polish. And this is a very interesting case of working with the IVENEER matrix and doing layering technique with flowables. So the patient concern was regarding the short centrals. These are grinded teeth. And the objective was to restore the length and the shape of the teeth. So I decided to use the matrix together with the so-called layering technique with flowables. And why? The reason. Because if I would try to build this missing part with just with flowable one layer, probably I will end with gray restoration, because I need here the palatal shell, I need the dentin or the opaque layer, and then I need to inject the final layer. But this is very simple, because if we know how to do freehand palatal shell, we don't need to send it to the lab to do an index or to produce the index by ourselves. It's very simple just to build a very thin layer of palatal shell with our tip of the finger, or we draw it on a mirrors or on a celluloid strip. Then we can approach this case and finish it very nicely, and I will show you how. So first of all, I'm trying the matrices. I cut the wings, as I told you. I build, you see, I build freehand with a clean glove, okay, cleaned with alcohol, clean glove, a very thin layer with flowable, because it's so simple and fast. This is the palatal shell. Now, I cure it a little bit, finishing, because I want to be able to put the matrix again. And if it is too long, then it will be a problem for me. The matrices that I already cut and try to try again. So I finish it a little bit. And did you see, this is a AO3. This is an opaque shade. So I put a little bit opaque shade, work with a silicone brush, cure it, and now I can put the matrix again, close the opening, the small opening from behind to stabilize it and to create a closed system. I did it very fast here, I know. And then I use here a universal or a flowable composite universal, which is with chameleon effect, because I want to stay on the shade of the patient. I don't want to change the shade. Very fast, I inject it, and then I remove the matrix, finish and polish a little bit, and move to the other teeth. Look how I can push a little bit the gum and create a exceptional marginal fit. So the emergence profile is perfect. I remove again the matrices, a little bit finish and polish, no bleeding at all, as you see, and this is the final result. This is a layering technique with flowables. It's the same like with the paste composite, but only with flowable. And by the way, I have developed some techniques that I can even cut back, make some characterizations, white spots, and then I put the matrix again. I remove the stuck, the composite that was stuck in the hole, remove it with a probe. I cut more the wings. I leave only the interproximal surface very thin, and then I put it again and inject another layer, maybe enamel, juvenile enamel or adult enamel, or whatever. So I can work with this matrix to create the final layer with a very, very thin thickness that will be very uniform. This is a huge advantage. This one is another very nice case of how we can do mock-up. And mock-up is very, very important in our clinic, because the patient he has a concern regarding how it will look at the end. In this case, the patient concern was regarding the upper aesthetic zone discoloration. she had some chipping and color, and the shape wasn't for her taste. So the first step was that, and she asked, of course, how it will look. Sometimes I just start to work because they believe in what I can do, but in this case, she wanted to see how it will look at the end. So I addressed a mock-up. I did it by cutting the matrix, no etching and no bonding at all here, cutting the matrix, almost all the interproximal, just stabilizing it, no etching and no bonding, of course, stabilizing it with a little bit material from the palatal to close the opening, and look, very gently, I'm injecting the flowable composite material, so homogeneous, so thin homogeneous layer, and look how the shape and the color of the teeth changed immediately. But it looks so natural. It took me 1 to 2 seconds. And a little bit finishing. Now look, I remove it. The veneer, this is the composite veneer, and I use it like a semi-direct. I can use it, but I don't do it. I just, for the purpose of showing her, I remove it and I put it back. And the patient was thrilled. And then I give this very fast veneer, composite veneer that I did. I put it in a small box and I give it to her to show her friends and family. And of course, she came back to finish the process. This is another interesting case. See how many use cases we can do with composite. This patient came to me and he has a lot of problems, as you see. He has to do a lot of treatment, but he came to me with an old crown on tooth number 21, and as you see, there is root exposure and gum recession with periodontal disease, and the tooth is grade 3, I think, movable. And he asked me not to extract the teeth. He wanted to preserve it as much as I can. And I told him, listen, I cannot promise you for how long this tooth will you can keep it in your mouth, but I can change the appearance. I can make you smile now, and to do it fast without the need to go for another ceramic crown, which is, there is no logic in it. So I decided to do it fast, to do it in the clinic till he will be able to do something else. And look what I did. This is before, and this is immediately after. 25 minutes. Very fast. Just remove it, clean, etch. There is a metal core. Can you see? I'm etching and bonding. I put a palatal shell, put the matrix, and immediately, sorry, and I have to run it again. I was trying to, okay. So I will speak fast. And immediately, when I build the palatal shell and put the matrix and close from behind, I create a closed system. This is a pinko pack to mask, okay, the metal. And then I put dentin, I put the matrix, close from behind, cure, put one shade, another shade. I mixed 2 shades here because I knew that I had to mix 2 shades here. A little bit finishing and polishing, and this is the end result immediately. I think it's nice. So I want to show you here the last case of today, and this is the upper aesthetic zone for a beautiful young girl. She's not a girl anymore, but and her concern were the misaligned teeth, the grinding, the gaps between the teeth, and the shape and the color of the upper 6 teeth. 13 to 23, and we decided to do it with direct composites, of course, with the IVENEER. And I want to show you the process. First of all, freehand palatal shell. I want to explain a little bit about this freehand palatal shell. The freehand palatal shell you can do it. You can take an index or send to the lab, and he will give you back an index after waxing the teeth. But I do it with my finger because I want to control the technique. I want to be able to see the end result, and I can build it freehand, and I can cut it, and then I can see what will be the end result. So I want to control everything. So I build first of all, I build all the palatal shells, and then I cut the palatal shells to the way that I think this is how it's supposed to be. And then I continue tooth by tooth. I try the first one, I cut, I fit, make sure it's okay, close from behind, stabilize and inject. Remove it, the second one. I do a little bit finishing and polishing after I finish every teeth. I don't go deep into finishing and polishing, but just the interproximals, those areas which are supposed to be very, very smooth. And then this is the end result. She was thrilled. She was so happy. It warms my heart that when the patients are so happy and they leave my clinic with a big smile, non-invasive, additive dentistry. It's really fun. And this is another case. I want to give you some tips about how you can present your work with direct composites, because it's so fast and you can finish the process immediately, 1 hour, 1.5 hours. You can actually take not pictures but live clips of the process before and after. The patient speaks before and speaks after. Of course, you need his consent, but it works for me very, very well. So I take a picture. Of course I take pictures, but I take a live video a couple of seconds before, and then when I finish after 1.5 hours, in this case, I take another picture. This is a difficult case of a tooth which had a root canal treatment and discoloration, but I think she was very happy, and I was quite happy with the end result. So this is the tip. You can, with other treatments like ceramics, with many appointments, you cannot do it. Here you can see happy patient. You can solve his problems. You can make him happy in 1.5 hours. And you can see how she's thrilled. Looks amazing. She said, it's in Hebrew, she said, it's crazy. Okay. This is me with this beautiful patient. And I hope that at the end of this presentation, I was able to expand your perspective about direct bonding. I want to tell you that working with the right materials, the high quality materials, tools, and with the right techniques, tips, and tricks, this is not difficult. It is you do it every day in your everyday practice. Doing a simple filling is the same procedure. You will be able to enable, it will enable you to offer your patient really non-invasive or minimally invasive aesthetic treatments to enhance their smiles and restore their confidence. So thank you, and I want to invite you to learn this technique. So please follow this QR code. You have here a free online course. It's a concise 20 minutes online course about only tips and tricks and techniques. And I would love to hear if you have any questions and what do you think about the technique. Thank you very much.
Okay, Itay, thank you very much. Great presentation, nice tips.
Thank you.
And happy patients, which is probably the most important part of our life, doing restorative and prosthodontics. We already have some questions and more coming in. So let's start with it. Why do you cut the wings? In which cases?
Okay, I choose to cut the wings when there is tight contact points, because we were able to achieve thickness of 0.05 to 0.06 millimeters. Sometimes it's not enough to go in between contacts. So it is not a problem, because when we cut the wings, we leave this very thin area of the interproximal, and it serves like knives. So when you push it and it goes to the contact but don't pass the contact, it still creates pressure. And you can put Teflon or a mylar strip in order to isolate before, and then you can put it, and you can, when you close from behind the opening palatal area, you stabilize the matrix, or with wedges. So it's quite simple and easy. They just have to try and to see how to do it. And I won't cut the wings when we have a bigger diastema, or I can push the matrix through the contacts, or when we have gum recession or with movable teeth, then I don't need to cut the wings. Also, I won't cut the wings if I do a composite crown, because I need everything. I need all the way to the palate.
Good. What do you tell your patients about the longevity of the restorations using this system? And especially, what do you tell to Braxis?
So as I tried, okay, to not to convince, but to change the mind, the perception of the thinking. Actually, the composites of today, the universal composites, the high field, they have a really good flexural strength, and they are as good, as strong as the conventional paste composite. So the question about chipping or how strong it is depends on the two factors that I mentioned. One of them is the quality of the composite, because not all composites are the same. And the second one is to know how to do the load, or to keep the load, that it will be lateral movements, extrusion, intrusion. So they have to keep the load evenly.
So how about the Braxis?
With bruxism, what I do, I'm trying to manage the movements, and if I see that it works, eventually I give a night guard.
How do you correct the occlusion from the lower teeth in edge-to-edge bite?
How do I correct
the occlusion?
The occlusion in edge-to-edge bite?
Yes.
In the lower? Okay, I must say something. Okay, this technique is minimally invasive, but sometimes it is not non-invasive, but sometimes it's minimally invasive. So if I need to do some correction, enameloplasty on the lower teeth, so I will do it, but I will stay on enamel.
Great. What about mandibular teeth? Does this work?
We don't have right now for the mandibular teeth. We will have soon. So at the moment, I do freehand flowable in mandibular teeth, but sometimes because except for the two centrals, you can take the other teeth, the laterals and the canine, and you can work on the lower arch as well.
Okay, an interesting question. After the resin shrinks with light curing, do you have voids at the sides since you polymerize at the center? do you have the resin retracting from the side?
No, actually, it's an interesting question, but because there is a shrinkage, you can see while you are curing the composite inside, you can see the shrinkage. You can see a very, very minor shrinkage, but there is a shrinkage. But it is not a concern in my for me, because I shrink it from the buccal and I shrink it from the side and from the palatine 2 times, and I use a very good curing lamp. And because this technique is using, it's not layering technique, so there are no layers inside. It's homogeneous composite, which is injected with pressure, and I control the bubbles. So I know that if I will cure it well, I won't have problem, and I don't have problem with this.
But how do you select the size of the template?
So we have two sizes. We have the small medium and the medium large, and we have only one shape because we realized that one shape, the triangular shape, is good enough for most cases. And if we want to change the shape, we can just change the corner line angles. But the sizes, we discovered, we realized that 2 sizes is enough to cover most of the cases, because this is somehow 90% of the size of the teeth. So it will fit. There will be no problem.
Okay. Probably this question comes from one of the last cases you showed. Application of this technique in periodontally involved teeth with mobility and root exposure.
Yes.
Would you do that instead of a conventional crown?
Because this tooth is about to extract a year from now or maybe earlier. So I didn't think it will be wise to replace it with another ceramic crown. I mean, not because I know that I can do a job which will be at least as beautiful and will sustain as a ceramic crown, and I can do it fast and I can save some money to the patient. So I didn't think I should do it, and the result is great, and the patient is happy. I think it's a very good alternative, in my opinion. That's what I'm trying to teach, to show.
Okay. Do you prepare the teeth to avoid orthodontic treatment and then use IVENEER?
No, I never prepare the teeth in a way that we prepare for ceramic crown. As I said, it's either it's non-invasive, so it's only additive, or I do a minimal interference. So I do minimal preparation. But sometimes, yes, I do minimal preparation, not deep as with ceramic veneers, but yes, I can do it. I still think it's more conservative than doing ceramic veneers.
Somebody is asking if you could, if it would be better to supply a kit with wings and a kit without wings, so you don't have to cut them. This is
I mean, the beauty of the system. Okay, the beauty of the system is that you can manipulate, because sometimes you need, sometimes not, and we don't want to complicate the system to have many matrices and sizes. There's no reason for that, and cutting the wings is part of the process. So it takes half a second.
Good. Would you use this technique on teeth that have interproximal caries?
Yes, of course. Why not? I always say that as much as the tooth is destructive and looks bad, it will be better for me, because once I have a little left from the teeth and I build the palatal shell and put the matrix, so it's easier for me to restore it. Of course, I will do it.
Another colleague asks, I would like to ask, what do you check when you change not only the shape, but also the length of the upper teeth? Does this changes the occlusion?
If it, if you change the occlusion, most of the time I work on the upper 6, 8 teeth. So it doesn't change the occlusion unless there is a tête-to-tête or something, but it doesn't change. And afterwards, I check the occlusion. I check for extrusion, lateral movements, and I see if I need, I correct the occlusion. I can add to the canine, so I can do things with composite to make sure that the occlusion is okay.
Another colleague says his main problem is with anterior composites is that we can see the margins between the composite and the tooth. How do you solve this problem?
Oh, I think it's totally wrong, because composite bonding or direct bonding is, I think it's the best material not to see the margins. We can control the margins. We can control the margins better than any other material. So if you know how to prepare with the beveling, and you know not to leave unsupported prism, and you know how to work with the composite and the brush or the matrix when you inject everything, so there is no problem. Controlling the margin is the best with composites.
Can you reuse the templates?
Okay, I have to be honest. I can reuse the matrix on the same patient, because sometimes I need to do another layer. But you can, but I won't do it for another patient, because then you have to deal with the cross-contamination. And I don't think it's fair for the patient to come and pay a lot of money to use something which costs $4 and to try to save on him. So, you know,
the answer is no. Yes.
It's not a fair question, you know.
Yes. Well, that was our last question, Itay. And I told you before we started that we have a nice, very intelligent audience, and so see that you created some movement. Judging from the questions, there are a lot of congratulations coming in, but we try not to read all this. So I will I would like to thank you for tonight, and I will turn you back to Mr. Tsaprazis to close for the seminar.
Thank you very much, Professor. Thank you, Iris. Thank you very much for inviting me and letting me speak.
Ωραία, να καληνυχτήσω από τη μεριά της εταιρείας Τσαπράζη και εγώ, και να ευχαριστήσω τον Dr. Itay για την ενδιαφέρουσα παρουσίαση και την προσθετική εταιρεία για το support που μας έχει κάνει. Ευχαριστούμε πάρα πολύ. Καλό σας βράδυ.
Εμείς σας ευχαριστούμε και σας περιμένουμε στο επόμενο webinar. Ευχαριστούμε πάρα πολύ που ήσασταν μαζί μας και σας εύχομαι ένα υπέροχο βράδυ. Καλή νύχτα, Iris. Bye bye, Dr. Itay. Thank you very much.
Thank you very much.
Thank you.
Thank you.